Right. Dr. Wick, can you see my slides?
Yeah.
Excellent. All right. It's 7 o'clock Central Time. Good evening, everyone, and welcome to tonight's webinar, Optimizing Sperm Health, What Men Can Do to Support Fertility. My name is Irina MacArthur. I'm Director of Patient Experience at Inception Fertility, and I'm very glad you're joining us today. Leading tonight's discussion is Dr. Michael Witt from Reproductive Biology Associates Clinic in Atlanta. Thank you very much, Dr. Witt, for leading the session today. I also like to mention that we will have Q&A session at the end of the webinar, so please feel free to submit your questions in Q&A box. We'll have a designated time to answer as many questions as we possibly can today. And if you'd like to ask your question live, which we actually very encourage and prefer, just please raise your virtual hand and I will unmute you when we'll get to Q&A portion. So thank you once again for being here with us tonight, and I'll turn over to Dr. Wheat.
Well, it's great to be with all of you tonight. And like Irina said, my name is Michael Witt, and I'm based out of Atlanta at Reproductive Biology Associates. I'm a urologist there and have been with that practice since 1995 and joined that group mainly so that we could provide sort of comprehensive care for the whole couple, with most of my colleagues taking care of the female side, but then I'm particularly tasked with taking care of any sort of issues that have to deal with male infertility. And as a result, we've been able to provide couples with the ability to come to one place to treat sort of both partners at the same time if that's needed. That's also helped us really coordinate pretty efficient and effective treatment plans, being that we both collaborate, me with the reproductive endocrinologist and them with me, on how to approach the treatment of a couple. And that's helped them, I think, optimize their ability to get pregnant with kind of whatever strategy they're open to using with the time frame that they desire. So tonight we're going to talk specifically about how to optimize sperm health and what men can do to support fertility. But I'm sure this will raise a lot of other questions. And so feel free if you have questions that have to do at all with male infertility, not even specifically related to this topic, to ask them, and we'll try to get them answered as much as we can at the end of the discussion. So next slide, please. So this is just an important disclaimer. It really is just to tell you that, what we recommend here, you definitely want to be sure if you proceed with any kind of treatment plan that you consult with your provider, and don't try to use this predominantly, for, your own management, but use it as kind of information that you can use to equip yourself to be able to discuss with your provider, different treatment plans or diagnostic strategies. Next slide, please. So if you look at the causes of infertility, what you find is that in about 50% of cases, there is a male factor that can make it more difficult to establish a pregnancy. That's why it's important at the outset that you have an evaluation done for the husband or for the male, really with any couple that's attempting to establish a pregnancy, even if it doesn't appear on the surface that there might be an issue. That's because, one, that helps you identify a problem early on in the process. You don't like to go too far down the assisted technique pathway and then discover that there's a male factor that's compromising outcomes, and then feel like you wasted time, wasted resources without a successful outcome, only to find you may have to repeat that whole process after the male's been seen and evaluated. And so we recommend that every male at least be seen and worked up so that we can identify if there is a factor or not. It's also important to know if there's not a factor, because if there's not, then that kind of takes you down a very different pathway as well. And it's important to know what those options are, as opposed to not considering yourself as being, part of the equation. We know that in the male, there's a host of factors that can create issues that can make it harder to establish a pregnancy. And these really can break down into two broad categories. They either have to do with how the sperm is produced, or they have to do with how the sperm is transported out of the testicle and into the ejaculate. And you can see a list there on the right of all the potential problems that can exist, such as a varicocele, infection, some kind of obstruction, hormonal issues. You can have genetic issues. There can be, primary underlying health issues as well that can cause problems, such as diabetes, hypertension, um, also, medications can be a huge offender. If there are specific medications that the husband's on that can either affect how well the sperm are made or transported. A big offender that I've currently seen a lot of is that men are on testosterone because it's so readily available now. And there's a lot of bioidentical clinics that you can access just on your own to get treated. And it's not uncommon for men who are complaining of sort of loss of energy, or they just feel like they don't have the ability to make it through the day, visit these clinics, get put on testosterone without the advice that this can definitely negatively affect fertility. And so they'll show up in our clinic and there'll be no sperm in the ejaculate because of that. So it's important in kind of going through the workup just to kind of keep these causes at the front of your thinking. And there's obviously many more than's mentioned here, but you can see even from this list that there's quite a few that can come into play if there's a male factor. Next slide, please. So what we typically tell couples is if there's no suspicion that there's an issue, usually recommend that they at least have tried for 6 months, of trying to establish a pregnancy. If after 6 months of pregnancy hasn't developed, then the odds of that happening just naturally start to go down. There's some insurance providers and then some obstetricians who might extend that window to 9 months or even 12 months. But if there's a suspicion that there's a factor either on the male side or on the maternal side, then it's important to kind of seek treatment immediately. So if you suspect due to, let's say, some congenital issue on the male side that there's a problem with sperm production, then you may not spend much time trying before you might seek help. We also recommend that if the woman is over the age of 50, over the age of 35, that she seek treatment pretty quickly, just because of her ovarian age. The time for her to optimize the utilization of eggs that have sort of good fertility potential starts to decline pretty quickly. So even if there's not a suspicion that there's a maternal factor or even a problem on the husband's side, you'd want to definitely seek treatment if the wife's age is over 35. Next slide, please. So in the male, typically you kind of proceed with an evaluation the same way you would sort of diagnose any kind of other medical condition. And we approach that just like we would any other kind of medical condition. So in the male, typically that would mean you'd want to do a thorough history and physical. And that history and physical would focus on just general health. And that has to do with kind of what operations have been done, what kind of medications are they on, what exposure to toxins have there been there, such as testosterone, tobacco products, recreational drugs, along with any sort of childhood potential problems, such as an undescended testicle or a testicular torsion or any other operation that's been done abdominally, like for bladder issues. And and then you would then go into, after it's sort of a thorough, history, you'd then take, a pretty significant physical examination. Again, this is sort of an indication that you've had an evaluation, in that you definitely want someone to have sort of placed hands on you to sort of do a thorough physical examination. So it definitely is more than just filling out a form or answering a list of questions over the phone. You definitely would want to have an exam as a male. Again, that focuses on kind of general health issues, but at the same time, it can be more reproductive specific. So you'll look at sort of all those organ systems that can potentially affect fertility in the male. Obviously, most of the exam will focus primarily on the genitalia, but you'd want to make sure, that there's a thorough cardiac exam, that there's no abdominal issues that are present, such as incisions or old scars. And then you definitely do sort of a neurologic assessment as well. So that at that point in time then would lead to sort of specific testing once you've done that. But 70% of the time, you usually are able to make the diagnosis, or at least has a pretty strong suspicion of what's going on just based on the history and the physical. Next slide, please. So the cornerstone of the laboratory testing for the male is the semen analysis. And the semen analysis is sort of a unique test in the field of medicine because compared to most other tests that are done, there really isn't any sort of normal that we can define for the male. So it's important to realize that what the semen analysis can't tell you is whether somebody's normal or not. A lot of patients want to know if they're normal, and a lot of patients will sometimes come in and say, somebody told me my sperm was normal, but you really can't make that assessment because the sperm are produced sort of in an environment that doesn't have any kind of physiologic impact in any other part of the body. And so it's not a tightly controlled system. It's highly variable. But at the same time, um, we don't really know what is an adequate number of sperm for fertility. So what you can really tell based on the semen analysis is what's adequate and what's probable. What's adequate is usually used to help tell the couple, based on the numbers of sperm we're seeing and how well they function, uh, what would the outcomes be with that specimen in the different contexts of assisted techniques like intrauterine insemination or in vitro fertilization. The other thing that it can't tell you is if you're fertile or not, because we don't really know what is sort of the threshold you need to exceed in a specific couple for that sperm to be able to establish a pregnancy. So you can see situations where there's just very high numbers of sperm and a couple is really struggling to get pregnant. And then you can see situations where there's low numbers of sperm and the couples have no problems getting pregnant. So what the WHO has come up with is what's known as some reference ranges. And those reference ranges really have been done in a cohort of patients where there's been no maternal factor and the couple has been trying for a year. And based on that, they've defined these reference ranges to give you a probability of how likely you are to establish a pregnancy over a year with timed intercourse if there's no maternal factor based on sort of the numbers and the function of the sperm. You typically, when you're doing the analysis, want to be sure you do two analyses because it's a highly variable system. The way the specimen is collected can introduce a lot of artifact. And so you never want to make a clinical decision based on one sperm test. You definitely want to get an average. And if two sperm tests are really discordant or extremely different, sometimes that is even an indication, to do a third one. You want to be sure that you do the semen analysis sort of with a pretty standardized window of abstinence, and that helps you control a little bit of the artifact. Typically, that's between 2 and 4 days. Sometimes you can extend that to 5 days. All that really is used to do is to just help regulate sort of the equality of the specimens so that you can compare specimens to specimens. If you get windows of abstinence that are too short or too long, then you can get some variability introduced into the numbers that really aren't a reflection of what that individual is producing. You want to be sure that when you do the analysis, that you do that at a clinic that's capable of really processing the specimen adequately. Again, because there's really no standardized way to do this, like if you were doing, say, a cholesterol level or a potassium level, which you can kind of take to any lab and they can run sort of the analysis, and there's just standardized metrics for measuring that. You want to be sure you use labs, that are very proficient at doing this. Most of the time, that's going to be linked, to a fertility clinic. And what these clinics do is not only are they experienced because of the volume that they're seeing, but they also benchmark with other clinics, and that's how you ensure that you're getting sort of consistency in the analysis and the numbers that are being read. At the end of the day, what the analysis will tell you, and probably the most significant number to take away from all the parameters that are there, is it really will tell you what's the total number of active sperm in the ejaculate. And that's typically the product of multiplying the volume times the concentration times the motility. And that's the number that you can use to get a sense of what is sort of the overall quality of that specimen. There's a host of other things you can look at, and if you've done a semen analysis, you know that there's all these different factors that come out on the report, some of which can mean something. Most of the time, it's just important to look at what the total motile fraction is and not go down a lot of rabbit holes with the other things that are there. Next slide, please. Yeah, so let me just expand that a little bit. So yeah, so when you look at the semen analysis, essentially you'll be analyzing, what the number of sperm cells are there, and you'll look at the sperm, which primarily, if you break down the anatomy of the sperm, you'll see that it has this very specialized structure, consisting of a head and a midpiece and a tail. The head sort of contains the genetic products that are then delivered to the egg in sort of a package that enables itself to sort of attach and penetrate the egg. The midpiece is kind of the engine of the sperm, because attached to the midpiece is a tail, and that tail essentially gets sort of activated by the midpiece, and that propagates the sperm, particularly if the couple's trying to establish a pregnancy with intercourse. And that propagation then enables the sperm to sort of travel, from typically the cervix up to the fallopian tube, where an egg potentially can be released. And that sperm will usually be accompanied by an ejaculate fluid. That fluid is not produced by the testicle, it's produced by the prostate and some of the structures around the prostate. A lot of men get confused that the ejaculate volume is a measure of sperm number, and it's really not. The best way you know that is men that have had vasectomies who don't have any sperm in the ejaculate. They'll have the same amount of fluid, but no sperm. The amount of sperm fluid that actually contributed to the ejaculate is probably less than 0.1 cc's. But what that fluid does, it provides kind of a media and a protective environment for the sperm to get delivered sort of through the vaginal vault into the cervix and ultimately up into the uterus. Uh, Ejaculate fluid is important, and there definitely needs to be a certain amount of that present. But the amount of fluid that's there really is not correlative with how many sperm are there. There are some situations where you can have too little fluid or too much fluid, and that can sort of either create problems with transportation that has to do with poor contact with the cervix, or with just a dilution of the numbers, so that you're getting fewer sperm than what's reflected of the entire ejaculate, into the uterus itself. Next slide, please. So we've talked a little bit about the anatomy of the sperm, and here's just a diagram of that, and you can kind of see the different pieces of that. There's the head at the tip, and then there's that mid piece, which really contains the motor, which is essentially a mitochondria, and then the tail, which is made up of sort of these protein structures that look like columns that can help that structure sort of migrate and flagellate and then propagate the sperm. There's no other cell like this in the body. It's completely unique. And the body, the testicle will make, millions of these in the course of a day. Next slide, please. So here's sort of the different parameters that you'll typically see in the semen analysis, and we've talked a little bit about this. There's the sperm concentration. That's a number that a lot of people will fixate on. It's important to realize that that number is sort of indexed to volume. So it's measuring the number of sperm in sort of a defined volume, which we call a cc or a millimeter. So that concentration can go up or down based on the volume. And so you always sort of have to make sure, when you want to get a sense of how many sperm are there, that you're multiplying the concentration by the volume of the ejaculate, as opposed to just looking at the sperm concentration. That's important, particularly if you're comparing samples to samples. And then you'll look at what's called sort of the vitality, or we will call that sometimes motility. And that's just the percent of sperm that are active in the specimen. There's some clinics that'll break that down into sort of different levels of propagation based on sort of the uniformity of migration. Um, and that has some predictive significance, but only sometimes in certain settings. Usually you just want to look at the percentage of sperm that's moving. And then they'll look in most cases at the shape of the sperm. And this has the fancy term called morphology, which just means the shape of the sperm. Again, there's a lot of different ways people measure this. A real common one that's available is called the Kruger score. And it tends to sort of imply from shape how well the sperm is going to function. It's not always correlative. So you don't want to think that if there's poor morphology that the sperm's not going to work very well, or there's going to be a higher risk of problematic pregnancies, or some congenital abnormality with the actual birth. But if it's abnormal, you want to investigate that further. But it doesn't necessarily mean that there is an issue, it just means there's a suspicion of one. And then one of the things that can come up in the fluid that accompanies the sperm is what's known as white blood cells. It's important to know that on most semen analyses, the semen parameters that you'll get that'll sort of reflect that this could be a problem is called round cells. But the problem on the semen analysis is that a routine semen analysis doesn't differentiate between white blood cells and immature sperm cells. Both of those will look like round cells. And so if you can have a lot of round cells that sometimes get interpreted as white blood cells, and you'll get some people saying you have an infection based on that, when in reality, you just have sort of a higher population of immature sperm cells. That isn't necessarily a pathologic condition. Sometimes it can be, but it's just important to make sure you don't get incorrectly diagnosed as having white blood cells when essentially you have round cells. So if you see a high level of round cells, you typically will then run some other tests, and that's usually a monoclonal antibody test that will specifically attach to white blood cells. And you can then identify, is there a high white blood cell population or not? If there is, then obviously that would lead to investigation of, is there an infectious or an inflammatory condition that needs to be addressed? But if there's not, then obviously you would pursue, either investigating that further or treating that. Next slide, please. So here's typically what you'll see on the semen analysis as the parameters that are usually defined as kind of the reference ranges um, for the semen analysis. And again, as we said, they'll kind of look at pH and they'll look at count, which is known as concentration, and then they'll look at sort of the motility and then morphology. And this is kind of an abbreviated sort of reference range that you'll see on these. If you actually go to the 5th edition of the WHO, they'll kind of break this out even further to give you kind of probability scores based on sort of the different partitioning of these values as you go from sort of low to high. It's important to realize, and you can even see that here on this slide, that this doesn't mean it's normal. So if you fall into that range, it doesn't mean you're normal. Um, it just means that you might have adequate numbers of sperm, but you can kind of get a sense of what's probable. And then that's how you sort of counsel the patient as to what they can do with that specimen, and then how should they proceed with any further evaluation if needed. Next slide, please. So if you see a situation where you're in sort of this low probability category, and it's not uncommon for men to come into my clinic and they've had a semen analysis by their OB, or if they've done a home test, and they'll say, I just have a low count. That's usually just sort of a very broad term. But typically what that means is that they're sort of in a low probability category. It's important, if that happens, that you get that semen analysis, looked at by somebody who knows sort of how to interpret sort of all the parameters that are there. Um, Also, you want to make sure that you're looking at 2 sperm counts so you can confirm, is this sort of a consistent finding or not? But if you see this, then you start to kind of go through the differential diagnosis of what could be accounting for that. And again, that'll break down either into some kind of production problem or into some kind of transportation problem. And you can see if counts are really low, that you might suspect that there's some sort of chromosomal abnormality. And in about 20% of men, when you get a sperm concentration less than 5 million, there's an incidence of some sort of genetic abnormality that you'd want to know about and test for, mainly because that'll make the diagnosis immediately, but it will also potentially help counsel you as to what the risk is for using that sperm to establish a pregnancy for the offspring. You'd look at sort of hormonal imbalance. You'd want to make sure there's no sort of underlying vascular condition, which is commonly called a varicocele. And then you want to rule out any kind of blockage that has to do with sperm transport. The transport issues usually will be based either down at the level of the testicle in sort of the delicate tubular structure down there, or usually up by the prostate itself. It's not uncommon if you have a low count that there may be other things going on. So if an individual has, let's say, type 2 diabetes, and they're on insulin, and they can see really low counts and low volumes because they'll typically have a compromise in sperm transport due to an impairment of ejaculation. If the individual is, let's say, on some kind of hormonal treatment, then again, you can pick that up in the history, and that sometimes will also produce very low count or sometimes even a zero count. Next slide, please. So here are sort of some of the different causes that you can see, and we've sort of talked about these a little bit. A lot of patients will very commonly ask, is there anything I can do lifestyle-wise that can sort of help improve sperm count? Usually the things you want to stay away from are any kind of inhaled tobacco products or recreational drug use, or anabolic steroids or testosterone products. Um, Alcohol typically doesn't have to be restricted as much as it does in women who are trying to get pregnant. Obviously, there's not a good reason to drink alcohol, but it's been shown if you keep alcohol consumption sort of less than 10 drinks a week, you're probably not going to negatively affect fertility. Obesity is definitely an issue that's, very common, and the obesity sort of in and of itself is not problematic, but what the obesity can do is it can create hormonal issues, or it can create other medical conditions that can affect how well that individual manufactures sperm, or sometimes even transport sperm. So I'll tell most men, be on a diet, that's causing your weight to be in a healthy place, but there's no real magical food to eat. There's nothing, that you can take specifically that's going to negatively or positively affect sperm production. But just be on a diet that's keeping your weight in a healthy place. Um, you can check for environmental issues, and usually that would have to do with sort of radiation or chemicals. If you're exposed to a lot of pesticides, sometimes that can have an impact on sperm production. Heat gets a lot of press, but heat in and of itself, if it's just environmental heat, typically doesn't have a negative effect unless it alters the core body temperature. So if you were to get like heat stroke, or if you were to develop sort of a fever of 102 degrees that lasted longer than 48 hours, that kind of elevated core body temperature sometimes can transiently affect sperm. But usually most of the environmental things have to do with, you know, substances that you know are going to potentially not just negatively affect sperm, but also other areas of the body. Um, and then, with the medical causes, you're mainly looking at kind of medications that they're on, hormonal imbalances, any history of infections that they've had, whether that's epididymitis, or whether that's been a bout of mumps, or whether that's been sort of a recent, severe viral infection in which they had an elevated temperature. And then you kind of look and make sure that there's nothing else going on structurally within the testicle in terms of its position, or if there's any sort of tumors. Stress management for men typically isn't as critical as it is for women. But what usually happens in most situations with men is that if the stress is causing harmful secondary behavior, then that's usually where you can see some issues develop. So if it's causing the individual to smoke or to use sort of recreational drugs, and cannabis is, being more and more widely abused, and it's as a result can negatively affect hormone production and then sperm production. That's becoming a bigger and bigger problem, that I'm seeing as a contributing factor to sort of poor sperm production. Uh, but if the individual is depressed and then has to go on some sort of serotonin reuptake inhibitor that can negatively affect ejaculation or sperm transport, then those can cause all kinds of secondary problems, with the stress not being the primary cause, but it can lead to sort of other secondary behavior that can produce a problem. And so you try to kind of manage the stress to avoid, all those other issues. Next slide, please. Oh, if you want to look at sort of what to do health-wise, it's kind of the same advice that I've kind of given men in regards to their diet. Um, Exercise isn't bad. Some men come in and say, should I stop exercising? I'm sweating and I feel hot, and my wife's told me that's not good for me. I'll tell most men, no, exercise is probably what you want to do. There's not too much exercise that you can engage in. And mainly you want to use the exercise the same way that you would use your diet, which is just to control your weight and to keep your body mass index sort of in a healthy place. Um, Typically that exercise, you just need to avoid sort of performance enhancing drugs, which you can take, and some men are on for that. But if you do that, you're going to really shut down your sperm production. So you want to stay away from those. But like protein drinks are fine, and hydration's fine, and working out is good. Um, and then you want to, as we said, kind of keep alcohol consumption sort of in a healthy place, probably less than 10 drinks a week. Um, oh, yeah. So next slide, please. Yeah. So then we'll kind of talk about some of the different treatments that you can use. And, treatments kind of range, from trying to sort of correct the underlying problem to sort of compensate for the underlying problem. And which of those pathways you pursue is highly dependent upon what the goals of the couple are. So as when you get to the treatment discussion of what to do, it's important to factor into that, how quickly you as a couple want to get pregnant, how many pregnancies you want, what kind of assisted techniques are you willing to use, when are you willing to use those, and as well, what maternal factors exist. Um, if you're trying to sort of correct the underlying problem, so let's say there's a varicocele, or let's say there's been a vasectomy, um, you're doing that so you can increase sperm numbers and quality in the ejaculate, usually to make it easier to get pregnant with timed intercourse. And those treatment plans usually tend to be kind of less expensive and a little bit more effective at getting pregnant in most cases. But the downside is they can take more time and there can be a little bit more uncertainty. And so there are some cases where you might just compensate for low numbers or poor quality by moving immediately to assisted techniques, because that can usually compress the timetable, to get the higher pregnancy rate. If there's some easily reversible causes, like just coming off testosterone, or switching medications, um, or starting a medication to correct an underlying, hormonal imbalance, then obviously that's easy to do. But again, what happens if you're trying to sort of correct the underlying problem for men, particularly if it's a production problem, is you're really dependent upon the life cycle of sperm production, which is about 90 days in length. And so usually any treatment you implement for production issues, there's going to be sort of this waiting period to see if there's a benefit. And so that's why it can take longer if you're trying to treat the condition than if you're trying to compensate for it. But which of those paths you pursue is kind of dependent upon what your reproductive goals are. And I'll tell most couples they're not mutually exclusive in most cases. So it's really kind of deciding which one to do first once you've had that discussion with your provider. Next slide, please. Let's see. So I think we're moving on to, is this the assisted techniques? Yeah. So these are the different assisted techniques that you can use if you're trying to sort of compensate, for a male factor. Usually that has to do if you have sort of low numbers, or if you can't deliver sperm. And those usually have to do with either getting the sperm closer to the egg, and you can do that by putting sperm into the uterus. That's called intrauterine insemination. Or you can actually take the sperm and put it into the egg, and that's called in vitro fertilization, with intracytoplasmic sperm injection being sort of the most common technique that's used today. Um, there are sort of different numerical requirements of sperm for each of these techniques. Usually, for IVF, you like to have at least, 500,000 active sperm in the specimen. It can be lower than that in some cases, but usually you like to have that as kind of a minimum number so you're getting a good population to select from. Whereas with insemination, typically they like to be able to inseminate about 5 million motile sperm, to have a reasonable outcome. You're always going to get higher pregnancy rates with IVF over a shorter period of time, but obviously that's more involved. Um, you're going to get kind of lower pregnancy rates over a little bit longer period of time with IUI, but can be less expensive and kind of less involved and invasive. Next slide, please. So if you want to look at kind of the supplements that are out there, and this is a very common question that I get in terms of what can I take, what can I do, and it's not uncommon even for men to be on these already when they come into the clinic. Um, the the things that have been shown to affect some individual sperm parameters are sort of these specific nutrients here, such as CoQ10, L-carnitine, vitamin E and C, zinc, folate, and selenium. What none of these studies have shown, though, is they haven't been shown to help fertility per se. So they can affect individual parameters, which is good. Uh, but by taking these, I can't really tell you how much it's going to impact fertility. So that means it's important to realize the limitations of these sort of nutrient-based supplements. It's not bad to take. Usually they don't cause any harm. But you want to realize it's not a magic pill, and it's something that you would do in addition to kind of treat the underlying cause specifically. Sometimes these can be pretty expensive, so it's important to realize there is usually a cost involved in some of these specialized formulations. I'll tell most men, if they really want to be cost conscious, you can probably almost accomplish the same things as you get with these expensive formulations just by taking a male multivitamin once a day. And the data would kind of definitely support that. In addition to the fact that daily multivitamin use has been shown to improve longevity, which is good if you're trying to build a family. Next slide, please. So some of the myths that are out there that it's good to debunk, just to keep you from getting too obsessed or kind of running around in circles, is that underwear doesn't really have any impact on your sperm production, so you don't have to change your wardrobe in that regards. Also, things like hot tubs, um, saunas, jacuzzis, Mountain Dew, cell phones in your pocket, laptops on your lap. Those have not been shown to negatively affect fertility in any way. So for most of these things, I'll just say use common sense and don't get too obsessed about them. Men also, as opposed to women, do make sperm through their entire life. Now, it does start to kind of decline in quality after the age of 50, both numerically and structurally. So it's important to recognize there is a slight decline there, but not like with women, where they'll just stop producing eggs at age 50. And then, as we've sort of discussed, supplements don't guarantee fertility. What you want to be aware of is that sperm quality gets poor with age, and that the supplements, as we've said, don't replace medical care. Next slide, please. So it's important to realize that your lifestyle is important, and you just want to maintain kind of a healthy lifestyle through exercise and diet as much as you can, and then just be sure that you get an evaluation, and that sometimes can help lead to a diagnosis that might lead to other treatments that are going to be much more effective. Next slide, please. Good. So we'll just kind of open this up for questions and answers. And I think Irina will kind of field those and then get them to me, and we'll try to get as many answered as we can.
Wonderful. Thank you very much, Dr. Wade. There's a lot of information that we covered today, and I learned personally a lot about this subject, so thank you. So our first question is training for a marathon considered to be an excessive endurance training?
It is considered excessive endurance training, but it hasn't been shown to have a negative impact on fertility. There have been some studies in sort of pro male triathletes who are running more than 120 miles a week that you can see some slight drops in testosterone, but that hasn't equated into a change in fertility. So most people who are running aren't pros. Most people who are training for marathons aren't running over 120 miles a week. So as long as you're doing it healthy wise, then and it's not causing any injuries, then it's okay.
Wonderful, thank you. All right, Ashley, I see your hand up. I will unmute you and you can take over. Just a second. Perfect.
Hi. Hi, my name's Ashley. My husband and I were able to successfully get pregnant with his low count due to Clomid. He took Clomid,
Mhm.
which seems to be a newer thing for men. I guess my question is, what are there any negative long-term effects of him taking Clomid for the duration of our childbearing years, so to speak?
Right. Yeah. Yeah. So, Clomid was initially kind of used and got FDA approval early in the 70s for ovulation stimulation for women. But it became starting to be widely used by men to sort of create the same level of stimulation for sperm production, in appropriate cases. Um, if it's working, and it does so because it increases signal intensity from the brain to the testicle to make sperm, it can have some side effects, and the things you'll commonly see that can be problematic over time is if the dose is too high and testosterone is too high, you can get what's called some downregulation of FSH receptors in the testicle, and you can see sperm counts drop sometimes in that setting.
Mm,
It also has to be processed by the liver, and so you just have to make sure that you don't get any sort of ongoing liver damage. If somebody's on it for more than 2 years, there's a possibility it could affect bone density, because the Clomid works by sort of altering the estrogen receptors, and that has sometimes some impact on bone formation and reformation. And then if the testosterone's too high, you can sometimes see problems, with getting what's called polycythemia, which is just too many red blood cells.
mm,
So it's important if you're on the Clomid, you get monitored every 3 months, usually with blood work, and as long as you have reproductive goals, a sperm test. If everything stays sort of in a healthy range, I've had guys on it for 10 years.
nice.
And then a much more common use of the Clomid now is to help men with low testosterone,
Mhm.
because it has been shown to elevate that without sort of altering the physiology like giving somebody testosterone does.
Good. Thank you very much.
Yeah,
Thank you. Our next question is, do you have any advice on how to improve abnormal sperm head morphology?
I do. One, it's important to figure out if it's definitely having an impact on sperm function, because, like I've said, it's a non-specific test. So in most men who I see that have a low morphology in the context of a couple that isn't getting pregnant, particularly if the sperm numbers are adequate, I'll usually do some sperm function testing. If that sperm function testing, which will look at sort of fertilization, penetration, and embryo development, is okay, you can just kind of ignore the morphology. Okay. But if the sperm function is abnormal, then you want to look for the underlying cause. And then you can address treatment for that specific cause. And if that's hormonal, if that's inflammatory, if that's vascular, if it's some kind of transportation issue, all of which can kind of create those, then you'd want to talk about treating those. And that's if you're trying to improve the number so it's easier to get pregnant naturally. You can also, if it looks like it's having an impact on function, compensate for it by doing IVF or IUI.
Thank you, Dr. Wick. The next question is, how is it possible to get the right ovulation? I'm using the ovulation kit.
You like which one to use or how to detect it, or do you know?
Most probably. Is it possible to get the right ovulation kit? So most probably the question.
Yeah, I mean, there's all kinds of kits on the market. Uh, Typically, you want to use the ones that test sort of the early morning urine, and that'll look at what's called sort of the LH surge. Clear Blue Easy is probably the best one to use, but you can try different over-the-counter ovulation kits and see which one helps you kind of get the best interpretation of your ovulation. Sometimes they're difficult to read. If that's the case, then sometimes that's when you'd want to see your obstetrician, and then they may decide to kind of figure that out with blood work as opposed to urine testing.
Thank you. Dr. Reed, the next question is it's medical question about medicine. So if I mispronounce medication, please forgive me.
Okay.
Is arginine the same as I-carnitine? Did I
No,
pronounce it?
they're different, right? Um, Usually you'll have sort of L-carnitine, which is what you'll see, can affect, sperm motility. But the arginine is sort of a different substance that kind of affects sperm production. So there are different nutrients that sometimes can improve different parameters of the sperm.
Thank you. And how do I pronounce this correctly? The medication that you were just talking about.
Oh, usually you just want to be careful about, reading it. I mean, most of those things you'll get over the counter. And you can get formulations that have, both of those in them.
Oh, I
Uh,
see.
yeah, but you just want to kind of read what the contents are of whatever formulation you're taking and see if it has in it what you want.
Excellent. Thank you. The next question is, I will be doing my third semen analysis next week, recommended by urologists because my morphology was low. The first time was 2% and last one was 1. I wanted if there's any, I wanted to ask if there's anything especially I need to do to help to boost it. I've been taking as well Fertility for about a week and a half and can cause infertility issues.
Right. Well, I think you're doing the right thing in seeing the urologist because you'd want to first, figure out, is there something causing it? And they can probably, through the workup, determine if there's an underlying diagnosis that they would want to treat more than just taking, say, the Fertilade, which is one of those nutrient formulations. But you also want to have them kind of figure out if the morphology is really negatively affecting the function of the sperm. Because if it's not, like I kind of said previously, you can kind of just ignore it.
Thank you. The next question is, I'm a frequent cannabis user and had a semen analysis and the results turn out fine. If I don't want to give it up entirely, is there a recommended time frame where I can cut back, or there's a research to show if it's better to take edibles versus smoking?
Right. Um, Yeah, we don't really know what the dose is that starts to produce an effect. We just know that the more you take, the worse it gets. Now, if your sperm numbers are fine and it looks like they're in adequate ranges, um, usually the recommendation would be to really stop use altogether just to prevent any further deterioration. But if you're, and this is sort of what gets a little dicey, if you're using, say, it just on a weekly basis, um, as opposed to say daily, probably you're not going to see too much of an effect by doing that. So minimal use is probably okay. It's just the really consistent use that can be problematic. And obviously you want to correlate that with your sperm parameters and potentially your hormone levels.
Well, since we're staying on this subject, I'll ask you another question that I see in Q&A box related to this topic. Can marijuana affect sperm morphology overall?
Yes, it can. Yeah, it can affect numbers and function, definitely.
Thank you, Dr. Wade. The next question is it necessary to give blood tests for testosterone without any general issues?
Usually it is. Typically, routine blood testing for most men is to check the testosterone and the FSH and the LH, and sometimes prolactin. So that's typically, usual screening. One, even if you don't have any symptoms of low testosterone, it'll give you a baseline, and sometimes that can be important, even if it's normal, if you decide to treat anything that you can then monitor, how much improvement that is.
Thank you. The next question is, my husband is a marathon runner and often runs up to 10 miles on average. Can this negatively impact his fertility?
No, usually not. If anything, it might help.
Thank you. I have been taking male fertility support capsules. How does it take those supplements to help me in sperm quality?
Yeah, well, like we've talked about, the supplements, can sometimes change some individual parameters. It can sometimes take up to 6 months to see a change, but the data hasn't shown that they help fertility. So you're really taking those kind of like you would take vitamin C for a cold. Um, a lot of people do it, but there's really no proof that it helps fertility.
Thank you. The next question is, my sperm is okay, but my wife is not getting pregnant. What are the recommendation for the next steps?
So definitely you then want to make sure, your wife has an evaluation. And if she hasn't had that, then that's the next place and the next thing to do. If they do an evaluation, then they've identified a factor, then you want that corrected. If they've done an evaluation and everything's normal, then as a couple, you start to fall into what's known as unexplained infertility, which happens in about 10% of cases. That puts you in a good prognostic category. But then as a couple, you're starting to talk about, okay, how much longer would we try naturally before you might move to assisted techniques to get that higher pregnancy rate?
Thank you. The next question is, can you speak to the sperm QT test and potential benefits of this test?
What was the name of the test again?
QT test, just two
Oh,
letters, QT.
yeah, I haven't heard of that test.
And for a person who asked this question, if you can unmute yourself maybe, or raise your hand and I'll unmute that, you can ask that question live and maybe elaborate a little bit on your question. Would be great. So you mentioned supplements already and kind of went over this, but is there any, if you have to pick one maybe supplement that you would recommend for patients to take, what that would be?
Yeah, I would probably pick CoQ10 if you were to take any one. And most of the times you'll find that in a multivitamin, but you can find that as an individual supplement just over the counter.
Okay, thank you very much. And I don't see the raise hand, so we will most probably get back to that question for QT tests. I'm actually curious what that is. Yes, there's a question, follow-up question about the ovulation kit. I see who asked this question, so I'll most probably get back to you offline regarding maybe the recommended brand or type after this webinar. Thank you. My fiance and I doing IVF and purchased the eggs from donor bank, but have put on hold because of the low morphology, didn't meet the bank parameters. But I've heard there's still possibility the egg could still fertilize with low morphology. Is there any truth to that?
Yes. Yeah, what's been shown is that morphology really doesn't affect fertilization. Now, if you're in one of the shared risk programs, then most programs using shared risk, whether that's with donor eggs or even sort of fresh eggs or autologous eggs, they'll have exclusion criteria for those shared risk programs. And that usually has to do with the number of sperm that's there and the morphology. And they do that just as a way of trying to eliminate, well, trying to improve the chances you're going to get pregnant with the first cycle. Um, so some of those are kind of artificially induced, but the data would show that morphology doesn't negatively affect fertilization or embryo development or pregnancy rates in the context of IVF, and probably even more so with donor eggs, because those have been highly selected, and usually they're sort of optimal quality.
Thank you. Is bladder extrophy
Yes.
known to impact fertility for males? My pediatric urologist told me 20 years ago it wouldn't, but my semen volume and concentrations are low, and morphology is abnormal, approximately 99% abnormal heads.
Yeah. Yeah. I mean, the bladder exstrophy can definitely affect sort of the transportation of sperm. Because one, you can have some incompetency in the valve of the bladder after it gets reconstructed, so that you may not be ejaculating all the sperm in a forward motion. Sometimes you can have associated with that sort of damage to the tubing that transports sperm out of the testicle and up to the bladder or the urethra. And then sometimes you can have undescended testes associated with exstrophy that can affect sperm transport. So yeah, definitely it can. Usually you have normal sperm production in those settings, but more of a problem with transport. And that's sometimes based on the severity of the exstrophy and then what kind of reconstruction was used.
Thank you. Um, are hormonal treatments necessary for the assistant programs?
Like for the wife, you mean? Is it for the female?
There is no really elaboration on this question, but
Yeah,
perhaps you
I mean,
can
if
talk about
yeah, if it's for, let's say, IVF, then those women will be placed usually on a stimulation protocol with hormones. In some cases, you'll do that with intrauterine insemination. There are some cases where you can just use natural cycles with intrauterine insemination. But if you're doing IVF, definitely, or if you failed multiple cycles of intrauterine insemination, then they'll do ovarian stimulation in those settings.
Thank you. Um, a question is an interesting question. We have a 7-year-old child, and the child is sitting on my lap. Can this affect my sperm production?
No.
Thank you. After how many years you need to check your sperm so as to follow up your healthy sperm?
Um,
It's
yeah.
repeated test. How often would you recommend to repeat semen analysis?
Right. I mean, if you're trying to establish a pregnancy and you've had treatment, typically you monitor that every 6 months. If there's sort of an ongoing underlying problem, but let's say there's been successful treatment and a pregnancy, and you want to just monitor that to make sure there's no further decline, you might do that once a year.
Thank you. And we'll take one more question. My husband had surgery to correct his varicocele 2 years ago. We did 5 IUIs this year and they're all failed. His sperm count after being washed varied from 1 million to 6 million. I'm trying to avoid IVF. Do you think it is possible to get pregnant eventually from doing more IUIs, or do you have anything else would you suggest?
Yeah, so usually in that setting, pregnancies can still occur with IUI, or they can still occur with timed intercourse. But if there's been 6 cycles, usually the chances for pregnancy start to decline pretty dramatically, because the fact that a pregnancy hasn't occurred indicates there is still some underlying problem. So in that case, you typically want to try to improve the sperm quality and numbers. And so you'd want to talk about potentially treating, the male further with medication to try to improve sperm numbers before repeating the IUIs.
Thank you, Dr. Wade. Um, Dr. Wade, thank you once again for amazing webinar, a lot of great information. I just would like to mention as well, if you're looking to make a first appointment, there is an opportunity to schedule the consultation. Dr. Wade, what is the best way to reach out to you, and how the process look like, if you can briefly
Yeah, so you can definitely, contact our office at Reproductive Biology Associates. I don't know if Irina has that contact information, but we can set up a telemedicine appointment or even just a phone call. Um, Sometimes, if you're not in the local area, I can get you to a physician in your area that can do your evaluation. And so it's just getting you that information and making that contact. But definitely I can assist in trying to get you to the right people if you're not able, to see me sort of in the Atlanta metro area.
Thank you once again, everyone, for joining, and have a good evening. Goodbye.
All right. Goodbye.